Dr. Samer Garas of Ascension St Vincent.
Good morning, everybody. Thank you very much for having me here. It's an honor to be here. It's a great event. And thank you, Virginia, for all your planning for this. Really appreciate it. Well, this is, I give a lot of talks, but this is one of the hardest ones I've had to give because they said you have to explain cardiovascular disease, past, present, and future in 10 minutes in layman terms. No problem. We got this under control. We'll be able to do it. No worries. You see, you have to work the clicker. That might be a little harder. Figure this out, I promise. When I came here about 20 years ago, I was very honored to be part of one of the best programs, I think, in the area, and I think it's probably one of the best programs in the nation. We have a very robust cardiovascular program. We tend to be the leader every time there is any new innovations, and I'm very proud and honored to be part of our program here. We're one of the first programs to do open heart surgery, stents, multiple other new things, which I'm going to skip here just for the sake of time. And over time, that is important. But what we're going to talk about today is what I think is the transformative part of cardiovascular disease. If you think about the heart, it's very easy to think about it in three different terms. There's the plumbing of the heart, which you have blood flow. We deal about coronary stents. People come in with heart attacks. We go in, we open them, and they do well. We have the electrical part of the heart. People have rhythm disturbances like atrial fibrillation. They have ventricular tachycardia. People can have cardiac arrest, which is a different part of the heart muscle activity. And then with the transformative part that it's been ongoing for the past 20 years now, and it is the present and the future, is what we call structural heart disease. The heart itself has valves inside of it. They can have holes. There's a lot of structural problems within the heart. And almost always, anybody with a structural heart problem, whether it's a baby, whether it's a teenager, whether it's an elderly person, you needed open heart surgery to fix that. You need your chest opened, you need your heart opened, you need the valve taken out, which I've been saying this now, it's going to seem uncivilized in 20 years or so to think about getting people's chests cracked and getting their body opened in that way. So this is what has been transformative in cardiovascular disease. Now, that picture there shows multiple areas inside the heart that we're able to touch, we'll be able to fix, we'll be able to take care of without the opening of anybody's chest. So we're able to treat most of these things by catheter approach, and the crown jewel of all of these has been replacing the aortic valve. So about 20 years ago, the first aortic valve replacement was done through the leg, and I was a fellow at a conference, and everybody looked at this valve replacement, somebody went through the leg and put a new valve in there and just seemed insane. And at this point, that is the standard of care, and I'm going to go through some of that. So I'm going to talk about just a couple of topics of what the disease is and what the opportunities are, and then I'll show you some of the future possibilities we have going forward. So aortic stenosis. Aortic stenosis is one of the most common valvular heart disease that we see across the world. As we get older and as the population is getting older, the aortic valve, which works every beat of every heartbeat, opens and closes, tends to get a little bit sicker. It tends to get calcified, and it doesn't work as well. It's just like our knees, just like our hips. It just gets a little tired. And with the calcification of the aortic valve, you can't get blood out of the heart and you can't breathe. There's not enough oxygen, there's not enough blood coming out, and it can be a fatal event. It's one of the most deadly diseases that we have as we get older. And the treatment has been very simple. You just get a big chainsaw and you open the chest, split it open, and then you kind of open the heart a little bit, you dig in there, you take the old valve out, you scrape it out, and then you put a nice brand new valve in. It's great. You close it up and put some metal in the chest and you go home. That's just basically the treatment. It's very basic. But very, very basic stuff. Fortunately, we're able to do things a little bit easier now. And today is TAVR Tuesday. We've been doing TAVR on Tuesday for the past 12 years. And I'm a little bit late, that's why I'm dressed like this. These are the valves that we have. There's two main valves that are approved in the United States. Medtronic has one and Edwards has one, and these are the most commonly used one. Edwards is kind of the standard one. In Europe, they have a bunch of others, and there's gonna be some coming out. But the great thing about this is the newest iteration of the valve seems to be working fantastic. So but we haven't had to change it much. We're able to do a valve replacement literally in 20 minutes. You come into the hybrid operating room, you're asleep, the valve is replaced in 20 minutes, and patients go home almost always the next day. With a complication rate for the not-so-sick patient in 1%, only 1 out of 100 patients will have a bad stroke or death. Maybe a little bit higher for the very elderly, for the sicker patients. But that's remarkable for a new technology that is on its first leg. Our average length of stay in our hospital is about 1.4 days for the valve replacement, which is quite remarkable for a surgery that would have normally taken 7, maybe even longer days in the hospital. In 2021, we did our 1,000th TAVR. Probably by the end of this year, we're going to get up to 1,500, which is fantastic. And the American College of Cardiology does recognize centers with the most advanced and the best outcomes. So that's something that a lot of the centers across the country is going to be seeking to get, and we're very proud to be one of the first centers to be accredited by the ACC. Another disease process that we will see as we get older is the mitral valve. It's another valve in the heart, but it tends to get leaky instead of not working. So the mitral valve the leaflets cannot come together very well for multiple reasons. One of them, if somebody has a weak heart, they've had congestive heart failure, the heart enlarges. And when it enlarges, the leaflets don't come together. So what do we do with that? Again, very simple, chainsaw, open the heart, get the valve out, put a new one in, it's great. But we have different other ways to deal with that right now. One of the basic technologies we have is a clip. It's like a staple. So we go in from the leg, we go into the vein, we cross into where the leaflets are in the heart, and bring them together. Bring the leaflets together with a little staple. And that procedure, it does take about an hour. It's a little bit longer, and that reduces the amount of leaking that goes through the mitral valve. And this is technology, again, in its first generation, and that needs improvement. So it's not a definitive therapy yet. I think that's therapy that has future of improvement, and I'll show you one of the trials that we're involved in to try to get that treatment a little bit better. All right, my two next opportunities to talk about is reduction of stroke, because you're going to have one of my colleagues, Dr. Hanel, here talking about stroke treatment. He's at Baptist, but I would like to prevent strokes, not treat them when they come. So a little bit different treatments. So there's multiple causes for stroke. One of the most common causes of stroke is atrial fibrillation, and people need blood thinners for that. I'm going to talk about that in a second. But then another common cause of stroke that we don't talk about much, because we used to call it cryptogenic, which means unknown cause of stroke. But we found that those patients that have unknown causes of stroke happen due to some clots that form, and it goes to the heart, and it travels and goes to the brain. It's through an opening in the heart, and you'll see this up there. There's a little flap in the heart called the PFO, and clots can travel through that from the leg and go to the brain, and then you'll have to call your friendly neurosurgeon to say, hey, listen, there's a clot in the brain, can you please take that out? And they do an amazing job in saving people's outcome and lives, and incredibly so. But if we identify those patients, one thing we can do, instead of letting this happen over and over again, is we can put a device in there. It's a double-sided umbrella to close off that flap, and that reduces the chance of that happening anymore. And that's what that device looks like. It's a very simple device. We go into the heart, and we go ahead and deploy it. That takes also about 15 minutes, and patients can go home generally the same day or the next day. And I'm proud to be one of the part of the only centers in Florida to participate in the landmark trial for the RESPECT trial that led to the approval of that device. So that's in 2002 when we first started, and we were able to bring that technology not to just to Jacksonville, our community. Actually, this is technology now that's adopted across the world for treatment of those patients. And this was published in New England Journal, and now it has become the standard of care for patients that PFO. All the things I'm talking about here are only maybe 5 to 10 years available. So this is all brand new stuff. Another approach to reducing the risk of stroke in patients is the most common cause is atrial fibrillation. Atrial fibrillation strokes tend to be heavy, poor outcome, very expensive, elderly patients. And the treatment is this very nice medication you take that makes you bleed all your life, and if you fall, it'll make you bleed more, and if you bang your head, God help you. So the idea here is to reduce the dependence on those medications that I think are terrible and basically poisonous. So there's a device we call the Watchman device. There's another one in the market right now. Is we go into the heart and just put a plug in the little area where the clots form. It's called an appendage, and that's where the clots form. If you go in and you plug that appendage, then there's no places for the clots to form, and you don't have to be on blood thinners. It's amazing. That's not quite approved for everybody, but we are, again, part of a trial called the Champion Trial to look at giving everybody that therapy, not just some patients. Right now, it's approved for patients that already have a bleeding problem. But what we'd like to do is have that be the standard of care for everybody, whether they've had a bleeding problem or not. So we're part of that trial, and hopefully we'll bring that technology going forward. And we're about to do Watchman number 1,000 probably later this year. So very exciting approaches. And also, I can't forget to talk about some of the new imaging that's available in Jacksonville. All major centers here all have amazing cardiac MRI programs that allows us to see things we couldn't see before, and that improves our medical therapy. It improves our interventional therapy. And a couple other trials that I will mention is the mitral valve replacement trial that I mentioned. I said the mitral clip does need improvement, and now we're enrolling patients in the trial where we can replace the entire valve by putting this fancy device. It's a docking system. We go into the heart and you put that docking system in there, and then we can put a new valve inside to replace the mitral valve. So a lot of exciting new technology, but I do have to say that we have a lot of the new technology is available, and I'm very proud and honored to be here, and thank you very much.